We're going to talk about radiation-induced changes in the small vessels of the brain. And we're going to focus on the capillaries, arterioles, and small veins. And as a rule of thumb, you can call a vessel an arteriole if the size of the lumen equals the wall thickness. Radiation leads to endothelial damage, which leads to changes in the vessel wall and to the formation of cavernomas, best detected on susceptibility weighted images, capillary teleangiectasias, and to mineralising microangiopathy, which you can also see on CT. And we know this is mineralising microangiopathy and not physiological calcification in the lentiform nucleus because it is unilateral and located on the site where the patient had been irradiated after resection of a left temporal lobe tumor. Cavernomas are typically chocolate-covered popcorn lesions, and sometimes the radiation-induced cavernomas have the typical chocolate-covered popcorn appearance, but sometimes they look a little bit different. This is an example of a boy who had cranial radiation at the age of 13 for a suprasellar germinoma. At the age of 19, his MR was normal, and at the age of 21, there was a lesion with a sedimentation level and a hemosiderin ring that was also considered a cavernoma, but as you can see, this is not a typical chocolate-covered popcorn lesion. And the radiation-induced cavernomas are thought to arise from the release of vascular endothelial growth factor, and the threshold for that is a dose as low as 1 gray. And interestingly, radiation-induced cavernomas also become smaller with bevacizumab. There was a study in 2015 in the Journal of Neurosurgery where they looked at differences between radiation-induced cavernous malformation and sporadic non-radiation cavernous malformations, and they found that the radiation-induced cavernomas have a slightly higher risk of hemorrhage, and you can see in this patient who has had irradiation of his entire neurexis at the age of 24 that 10 years later there was a hemorrhagic lesion in his right hemisphere that changed inside, and that there were other cavernomas appearing. So there's a long latency between the radiation and the appearance of the cavernomas, which might be as long as 19.5 years. Because there's a slight difference between the sporadic and the radiation-induced cavernomas, where it has been shown that radiation-induced cavernomas have very few muscle in the wall of their vessels on this actin staining, and there's more macrophages in the radiation-induced cavernomas, so the term pseudocavernoma has also been suggested because it's not a true cavernoma. Capillary teleangiectasias are in the same spectrum as cavernomas. There are also dilated vessels, but there's some normal brain parenchyma in between, whereas in a cavernoma there are dilated vessels without normal neural tissue. And capillary teleangiectasias also are induced by radiation, as you can see on the T2 and susceptibility weighted images of this patient. Mineralising microangiopathy occurs when there is fibroid necrosis in the small blood vessels, and this leads to calcium depositions, especially at the corticomedullary junction, as you can see here, and in the lentiform nucleus, as we saw in the previous slide. And on histology, this is a very old image from 1986, but it still remains the same. You can see the small vessels, and with the arrowheads the calcifications are pointed out. There are other microangiopathies that you can put in the differential diagnosis of mineralizing microangiopathy. And another microangiopathy that also has intrinsic vessel wall problems is amyloid microangiopathy, and we're going to talk about that next time.